This is Dr. Marcos Reyes with Inside the Eye, and today we are going to talk about glaucoma treatments. As you can tell, there's a lot of them. If you missed my first video about glaucoma, please check it out before watching this video so you have a better understanding about the disease process itself. As a quick recap, we are trying to treat glaucoma. Glaucoma is when the drainage system inside the eye is blocked and the high pressure inside the eye causes damage to the optic nerve. This damage to the optic nerve causes a loss of peripheral vision, which slowly and unrelentingly can lead to blindness. And we want to prevent that and keep that optic nerve looking nice and healthy. So how do we lower the high pressure inside the eye to a more normal pressure? As with any plumbing system, there's a place where the fluid is made and a place where the fluid is drained. So we can increase the drainage or decrease the production, or both. Okay, back to my old slide deck. Treating the glaucoma patient, medical, laser, and surgical. As you remember from my initial slide, there are a lot of different treatments. Historically, we've started with eye drops first for most patients, but that trend is starting to change. As you can tell, there are a lot of different glaucoma drops. I've blurred the slide out to protect myself from the pharmaceutical companies. But eye drops are very helpful. They do a lot of what I said before. They can increase the drainage capacity of the eye, and they can also decrease the amount of fluid being made. Some drops do both. There are many different drop combinations that can be utilized, and here is an example of an eye drop schedule that could be used for a potential patient. With early stages of glaucoma, the glaucoma drop schedule can be quite simple, maybe 1 drop a day or 2 drops a day. But as glaucoma progresses, the schedule gets more and more complicated, and you can end up taking 2, 3, 4 different glaucoma drops multiple times a day. These multiple different glaucoma drops can have their side effects. Possible side effects of glaucoma drops include dry eyes, irritated eyes, red eyes, dry mouth because tears drain into your throat, eyelash growth. There was actually a cosmetic medication developed because of a glaucoma drop. Darker skin, darker iris, skin redness, and skin rash. Now, these side effects sound bad, and they can be, but most of the time, drops work just fine without any major side effects, thankfully. Okay, on to our next treatment, glaucoma lasers. Lasers for treating glaucoma have been around for almost 50 years or more. The first iteration, or the first type of glaucoma laser out there, was ALT, argon laser trabeculoplasty. It was followed by selective laser trabeculoplasty, and now there's another option called micropulse laser trabeculoplasty. All of these lasers target the trabecular meshwork, and the goal is to make the trabecular meshwork function better. Basically open it up a little bit so the fluid can flow through that meshwork and into the Schlemm's canal, where it can then be drained properly. There are many different layers to the trabecular meshwork. One is called the juxtacanalicular layer, another the corneoscleral, and the third the uveal layer. The lasers that we use help to modulate or open up the trabecular meshwork, allowing it to function more effectively. What's the probability of these lasers working to lower the pressure? Well, there are many factors, but these lasers are roughly 60 to 90% effective in lowering the pressure about 20 to 25%, depending on the type and the severity of glaucoma. Studies have shown that if effective, the laser results can last 3 to 5 years. In my experience, that is generally limited to a small subset of individuals. I usually get 2 to 3 years of effectiveness. If desired, the laser can be repeated until no longer effective, and eventually it stops working, and further therapy is needed. The side effects of trabeculoplasty are blurry vision for a few hours, eye soreness for a few days, and light sensitivity for a few days. The risk factors are it may not work, pressure spike occurs in 1 out of 1,000 patients, and very, very rare incidents of corneal swelling. The amount is unknown, but likely less than 1 in 10,000. The next type of laser we utilize to lower the pressure inside the eye is called micropulse cyclophotocoagulation. It works to decrease the production of fluid in the ciliary body. This laser is performed in the operating room under light sedation and a local block. Per the studies, the MicroPulse P3 delivery device has a success rate between 60 and 80% and can lower the intraocular pressure between 30 to 45%. In my experience, patients have a 50 to 75% chance of lowering the pressure, approximately 25 to 30%. But it can last up to 72 months with repeat treatments. The side effects are blurry vision for a few hours, eye soreness for a few days, and light sensitivity for a few days. The risk factors are it may not work, rare retinal swelling, and very rare persistent inflammation. This last section involves the surgical treatment of glaucoma. As with the other sections, there are many different options available, so many that I can't go into depth on all of them. I will only focus on the surgeries that I use most commonly. The first is a surgery that increases the capacity of the drainage system to flow. There are many different techniques available, but my favorite is the ab internal canaloplasty, or ABIC. This involves placing a catheter through the trabecular meshwork and into Schlemm's canal and threading the catheter 360 degrees all the way around Schlemm's canal and using a heavy jelly to dilate and stretch open Schlemm's canal, the trabecular meshwork, and the associated collector channel system. The best way to conceive of this is by thinking of a flat fire hose. When fluid starts to flow through it, things really start to move. The ability to stretch open the collector channels, the trabecular meshwork, and Schlemm's canal can be tremendous in helping lower the pressure. This surgery can be augmented by placing a stent within the newly dilated canal. There are a few different options available. One is the Hydra stent, another is the iStent, and there is also the second generation iStent. Ab internal canaloplasty combined with stents has a side effect of 1 to 7 days of blurry vision due to red blood cells inside the eye. And there are also two risk factors. One is it could be unsuccessful. The pressure could not end up low enough to protect the optic nerve, and you could go on to need a further surgery. Two, the stent could end up blocked, resulting in high pressure again. In my own experience, 85% of my patients end up with a pressure 35 to 40% lower than before the surgery. If the natural drainage system fails, we have to look at bypassing the natural drainage system and doing what's called a filtering surgery. Think of it very much like if a heart stent fails, the next step is a heart bypass. All types of filtering surgery involve creating a connection between the anterior segment of the eye and the subconjunctival space. The conjunctiva is the mucous membrane that covers the white part of the eye. If the filtering surgery is successful, then a patient will have a low-lying blister of fluid. Think of it like an external reservoir that is covered by the upper eyelid. We call this man-made blister or external reservoir a bleb. The difficulty with this surgery is determining how a patient will scar because everyone scars differently, and for that reason the blister can look a little bit different from patient to patient after surgery. We use chemotherapy anti-scarring medications to help most patients obtain a nice looking blister of fluid hidden by the upper eyelid. For the last few years, my most consistent and best results have been found using what's called a Zen gel stent. Most of my glaucoma colleagues and I agree on this. However, there's a new device coming out, I think next year, called the InFocus Microshunt that may be even better. If these initial surgeries fail, the next step is what's called a tube shunt. This involves placing a larger tube inside the eye and connecting it to a silicone plate that is approximately 1 centimeter from the cornea and next to the extraocular muscles. All of this is covered by the conjunctiva, again creating a blister of fluid, but this blister is a bit further back, covered by the upper eyelid. In a handful of cases, I've had to place 2 of these tube shunts into someone's eye to control the pressure. The side effects of filtering surgery are blister of fluid called a bleb under the eyelid, temporary eye redness, temporary eye sensitivity. The risk factors are 15 to 20% of patients will need an enhancement. Rarely, the surgery will be unsuccessful, resulting in high pressure afterwards. Even more rarely, eye pressure being too low, droopy eyelid, double vision, cataract formation, permanent eye sensitivity, and permanent eye redness. No technique or surgery is 100% successful in controlling someone's glaucoma. For that reason, we start with non-invasive therapies first and then move up as needed. We will do whatever it takes to control someone's pressure to prevent further vision loss. Every step we take and every choice we make is to control the pressure of the eye to prevent optic nerve damage, because once the optic nerve has been damaged, there is no getting it back. Prevention is the name of the game. We want to prevent vision loss. For those of you with a family history of glaucoma, please consider getting screened earlier on in your life. We want to keep your vision as bright as possible. As always, thanks again for watching and please subscribe. Have a good one.